When you inspect the shoulder, what you want to notice is any asymmetry. Specifically, you want to look at shoulder height to begin with. You want to follow the clavicle out and look for any obvious separation as a sequelae of a separated shoulder at the acromioclavicular joint. One that has a remarkable step off here suggests that they've had a previous AC separation. You want to look for obvious muscle atrophy of the trapezius on either side. Keep them up there. I'm going to resist and you don't let me bring it down. And what I'm going to do is flip the skeleton around at this point because on inspection there's some important things to note from the back. You may notice when you ask the patient to stand up, they may be tilted to one side or the other, reflecting a great deal of paraspinous muscle spasm, trying to keep them in relative comfort. On inspection, there's a few things you want to notice. You want to look at the trapezius on either side to see if there's wasting on one side or the other. If there is wasting, it always needs to occur to you that you may have a primary neurologic problem as opposed to simply a muscular problem. And what I try to do is I try to look at the medial scapular stabilizers, specifically the rhomboids, the levator scapulae, and you want to look from the back and make sure that they look symmetric. Your fingertips against the wall, go ahead. Okay, relax. It's critical that when you see a patient with chronic shoulder pain, at least for the first time, you need to evaluate the neck. Okay, all right, straight ahead. Rotate that way as far as you can go. Have them go through active and resisted range of motion and make sure they have normal range of motion and strength. Your ear on your shoulder the other way. Good, okay. Now what I want you to do is do those things against resistance. I'm going to press against you and you work against me. Ready? Go. Press hard, press your forehead, perfect. Any problem when you do that? No. Okay, now backward. Okay. Now rotate that way, your chin. Good. The other way. Good. Okay, put your ear right here. Go. Okay, put your ear over here. Go. All right, good. Okay? Okay. Now just look straight ahead. And I'll also put vertical loading on the cervical spine to see if there's any evidence of disc herniation or disc protrusion. Because if there is, then although the shoulder complaint is the principal complaint, they in fact may have a nerve root problem. You need to investigate that first before you proceed, assuming that it's a primary shoulder muscular ligamentous problem. So I want you to go through some range of motion of the shoulder, and at any point if you have any problems, I don't think you will since you're here more for back problems. Just tell me if there's any problem doing these things. Okay, come all the way up as far as you can go. All the way up, okay, come on down. Okay, good, all right. Out to the side, and bring your hands all the way to the top, touch if you can. Okay, come on down. All right, good. Backwards, as far as you can go. Good, all right. Okay, now let's do those things against resistance. Okay. You're going to do them, and I'm going to make you work a little bit. Okay. All right? Put your arms out like this, straight elbows, straight up. Now press up. Okay. Now same thing, up. Good. Okay, now let them fall to the side and put your right hand back like that. Okay, resist. Ready? Go. Okay, good. Let me have you stay straight like that. Let me do it one more time. Good. Good. Now let's do it on the left side. Straight back. Go. Good. Okay? Now, you need to test internal and external rotators. And if you have pain that's chronic or acute and it's reproduced by external or internal rotator testing, that suggests that either as a primary or possibly as a secondary diagnosis you have rotator cuff involvement. And people typically will have pain on the lateral deltoid area. The maneuvers that reproduce the pain most strikingly are the rotator cuff resistance exercises. I'm going to do sort of the opposite. I'm going to have your thumbs point in. There is a specific maneuver called supraspinatus testing that shows reproduction of pain and is consistent with the rotator cuff strain. So again, rotator cuff strain can be reproduced with resisted internal rotation, external rotation, or supraspinatus testing. We do one examination for the biceps tendon. We have the patient's arm come up like this, and we put our finger right in here, and we have them do resistance this way. And if they have pain anteriorly, especially if you put your finger right here in the bicipital groove where the long head of the biceps goes and you feel tenderness, that's pretty consistent with long head of the biceps tendonitis. Like this. Now resist when I pull. Ready? Go. Ready? Go. Good. Now straighten your arm out all the way. Go. Go. Okay? Good. All right. One of the examinations you do is for anterior instability of the shoulder, which is an important diagnosis to make. And the way I try to do is I try to get my hand on the humerus and on the anterior and posterior shoulder capsule, specifically right here at the glenohumeral junction, if I can get my finger down on that. So I try to translate anteriorly and posteriorly, because if they're very lax, especially if it's asymmetric as compared to the other shoulder examination, then you know that you maybe have a primary ligamentous injury that may need to be repaired and not rehabilitatable, but you certainly know you have one deficit. One of the other maneuvers that we do for anterior instability is a test called the Fowler's test, where we will have the patient pretend they have a ball and tell me if you have any problem up here when I do that. Ready? Just start off, you know, sort of halfway and then start to build up speed. Ready? Go. Okay, now bring it. Okay. As you go into external rotation, potentially if you have an unstable shoulder, your humerus slides out this way, and they will describe anterior pain. Discomfort in the front of the shoulder. So I want you to reproduce that. And you say, okay, try to throw again against resistance, but I'm going to hold one hand here and fight you here, resist you here. They say, yeah, that does feel a little bit better. That suggests that they have anterior instability. Another test for instability is inferior instability, and what we try to do here was we see when we pull their arm down this way, you will see a normal sulcus in normal people, but if you pull it down and there's a remarkable sulcus that you can visualize, plus if the patient says, boy, I felt like something slipped, and you can in fact feel the humerus slip down, and it's very asymmetric compared to the other side, that suggests you have pretty remarkable ligamentous instability, and they need to be referred on to an orthopedic surgeon. Bring your arm across like this. Another test that we do is impingement, forcing the humerus up against subacromial bursa here. And when you do that and they hurt, that suggests that they have a positive impingement sign, which in and of itself is not diagnostic. It just is one particular sign of chronic shoulder dysfunctions. And if it doesn't hurt, then you do this maneuver. You force the humerus up further against the subacromial bursa. I'm going to have you face me again. Relax. Good. All right. Same thing on this side. Okay, relax that muscle right there, just let it hang. Good. Good. Perfect. All right. A couple more tests. Squeeze here. Squeeze here as hard as you can. All right, good. Okay. Cock your wrists up like that. Resist when I pull. Resist. Okay, now flip them over. Palms up. Cock them up this way. Resist. Okay, resist. Good. In any muscle strength testing, we use the Oxford scale of strength testing, wherein we go from 0 to 5. In clinical practice, you'll be diagnosing patients probably with grades 3, 4, and 5. But it's important in grading them because that's an index of how they're recovering. And you're going to go through some muscle strength. The patient I'm examining is not somebody who has a primary shoulder problem, but for our purposes is demonstrating what grade 5, 4, 3, and 2 look like on a shoulder examination. And here's grade 5 where he gives me a good resistance. Good. Okay, that's 5 out of 5. Now 4 or 5 would be a little not quite as strong. This is grade 4 where he gives me a little resistance, but he breaks when I prolong it. 4 or 5. Okay, now put these down. 3 out of 5. This is grade 3 where he can give me no resistance but can raise the shoulder against gravity or raise the arm against gravity. Good. Now, 2 out of 5. And here he's demonstrating 2 out of 5 strength wherein he can't raise it against gravity, but he can't move it in a plane that's not against gravity.